Hi, I'm Dr. Ken Iserson, and I'm your host for this program of 3 short videos. When and why do we need to ration healthcare resources, and what is the ethical justification? How do we plan for and initiate healthcare resource rationing? And who allocates the scarce resources, describing how to identify, train, and use crisis resource officers to ration resources at the patient care level. That video also discusses how risk communication techniques can make the entire system run more smoothly in crises. The key points for this video are: what triggers should indicate that healthcare resource rationing is necessary, what actions can be taken to ration healthcare resources, what general treatment priorities should be implemented, and why must the stakeholders, the affected medical and non-medical communities, validate the plan. Our first question is, what triggers should indicate that healthcare resource rationing is necessary? The best triggers are those that show that the demand has seriously exceeded the availability of healthcare resources. These triggers must be clear and unambiguous to healthcare professionals. Triggers must reflect the institutions, the agencies, or the team's current ratio of patient demand to available resources, resources such as personnel, equipment, and space. To be useful, triggers must be based on frequently measured and easily accessed data. For example, rationing might be triggered when a predetermined number of emergency department beds are filled with admitted patients, or by the percentage of filled inpatient beds. An incident that produces a large number of patients can also be a trigger. Some examples are industrial disasters, multi-person motor vehicle crashes, and terrorist attacks. The absence of one or more critical resources, such as computer systems, communications, electricity, water, or heat, for a significant length of time may trigger rationing. As triggers indicate increasing resource scarcity, healthcare professionals should initiate more stringent rationing. Initiating the plan requires the presence of people with the authority to activate the resource allocation plan when appropriate triggers are identified. These individuals must have clear authority to use altered or degraded standards of medical care. Our second question is, what action should be taken to ration healthcare resources? During a crisis, the goal is to maximize what scarce healthcare resources are available, especially personnel, usable space, and equipment. This can be accomplished by increasing the usefulness of the resources you have and by decreasing patient demand. In the pre-hospital setting, transport only salvageable patients. Do not waste EMS resources by transporting the dead. The appropriate use of alternative healthcare sites, rather than an over-reliance on acute care medical facilities, improves functioning of the entire healthcare system during widespread epidemics and other mass casualty crises. Before rationing life-saving resources in hospitals, you should stop elective admissions and elective surgeries, refuse transfers, transfer admitted emergency department patients to other institutions, discharge ambulatory inpatients, fill all physical beds, decrease normal nurse-to-patient ratios, and extend the scope of nursing practice and use all levels of personnel. Our third question is, what general treatment priorities should be implemented? During a crisis, when demand for healthcare resources far exceeds availability, the use of resources must be prioritized based on ethical principles. Here are some general principles for such a prioritization. First, treat those with the best chance of benefiting quickly from the available resources. This is based on the principles of medical success and conservation of resources. Next, treat those who perform essential emergency services, since such people may save many more lives if they can be returned to work. These people are called multipliers and include healthcare professionals, including emergency responders, with the skills and knowledge to perform in the current crisis. This is based on the principle of immediate usefulness. Caretakers for children, the elderly, and the disabled should be the next group to receive healthcare resources, since people in a caretaker role can also have a multiplier effect. This is based on the principles of beneficence and, again, immediate usefulness. The fourth group should be those who provide other essential services, such as police and fire protection, key communication personnel, societal leaders and key administrators, and key individuals within public service agencies. Any remaining resources should be fairly distributed to everyone else based on medical need, conservation of resources, and probable benefit. Our fourth question is, why is stakeholder validation vital? Stakeholders are people who will be affected by any plan that rations healthcare resources, including members of both the medical and non-medical communities. As John Shaw observed, disaster planners have not generally communicated the ethical underpinnings of their choices in a clear manner, but ethical issues have surfaced in public debates, often in the news media. Planners need to communicate with the public in advance of a health crisis, not when people are lining up at emergency ward doors. Stakeholder acceptance or validation of any planned resource allocation method is vital. Obtaining input about and then acceptance of a healthcare allocation plan ensures that the plan conforms to widely held societal values, allows medical and non-medical stakeholders to understand the difficult choices that must be made in disasters, and provides reassurance that decision makers will not abuse their power. In essence, the validation process helps to gain the public trust that practitioners, institutions, and organizations will need during crises. One way to get stakeholders to buy into a healthcare resource rationing plan is to use community focus groups. This results in a transparent decision-making process that's publicly accessible and open to scrutiny. The key to successful focus groups is to allow all stakeholders, the public, healthcare workers, and government representatives, to participate in the decision-making process. Healthcare leaders should respond to questions and be willing to revisit and revise decisions. Everyone benefits when stakeholders participate in the development of a crisis resource allocation plan. They can come to understand the rationing process, know that the plan is fair and reasonable, and realize that decision makers will be held accountable for their actions. Institutional and organizational bioethics committees can also work with focus groups to provide an ethics perspective on the need for and the process of resource rationing. Stakeholder involvement is vital, not only before, but also during a crisis. Providing them with information based on risk communication techniques can result in stakeholders being more willing to continue in their normal societal roles and to tolerate austere healthcare resource rationing. We'll discuss this further in video number 3. Thus, we can conclude that 1. Easily recognized and specific triggers must be what indicate that a resource allocation or triage situation exists. 2. Specific tested actions that healthcare workers can take must govern resource allocation. 3. Patient prioritization should follow a predetermined plan. This is often called triage. And 4. Stakeholders from the affected medical and non-medical communities should have an opportunity to approve this plan before it is implemented.